Good evening, everybody. We're glad that you are here, and it's so good to see people around the room at this time of the day. And we're quite excited even to introduce our guest speaker. But I'm first going to introduce our liaison, the person we've been working with from Michigan State University. And this is Mark Brevey, and he's the Director of Community and Government Relations at Michigan State University. And I'm Dejoke Ayola. I'm the Dean for the School of Health. So we're glad to partner with Michigan State University. And he's actually a Calvin alumni. So he finished from Calvin in 2004. Is that correct? Yeah. So we're glad to have you back here. We're glad for all these years of partnership, and I'm sure you'll be able to talk more about some of your experiences and partnership. So please, let's welcome Mark Brevey.
Thank you, Dean Ayula. And I realized when we were meeting with students earlier today, when I mentioned I graduated in 2004, it doesn't seem that long ago, but I'm pretty sure all the students in the room weren't born when I was here on campus. So it is always a pleasure to be back at Calvin. I think I mention it every year that we're back in this chapel. I actually first saw my wife greeting students coming into the Maureen chapels. And we went on an interim trip to Europe together. That's how we first started dating. Now, the January, what are they called now? They're not intensives. So I need to get with the new lingo here at Calvin. But anyway, like I said, it's always good to be back at Calvin. We've been doing this program here at Calvin for over 10 years. We appreciate every year all the work that goes into providing this opportunity and providing the space. So again, my name is Mark Brevey. I'm Director of Community and Government Relations at Michigan State University College of Human Medicine. And the reason we do this program is we have a partnership between Calvin and Michigan State University College of Human Medicine called the Early Assurance Program. So if you are a pre-med student, I would recommend talking to Dr. LaRue. She can give you a little bit more information on that program. I would like to note at the conclusion of Dr. Meghea's presentation, he will answer questions from the audience here in the room and those written into the Q&A feature online for as long as time allows. And I, again, do want to thank Dean Ayula and Dr. LaRue for the continuing partnership. With that, I'd like to introduce our speaker this evening. Cristian Meghea is a PhD, an NIH-funded associate professor in the Department of Obstetrics, Gynecology, and Reproductive Biology at Michigan State University. He is the director and co-founder of the Maternal Health Equity Lab. His experience is in maternal and child health, global health, health services research, health policy, and women's health. His research focuses on the prenatal and perinatal period as a window of opportunity to improve the long-term health of mothers and their children. Trained as an economist, I think this is the first economist that has presented at your health lecture series. He brings an evaluation and data and analysis expertise to this field of research. With that, let's welcome Dr. Meghea.
Thank you very much. Thank you all for being here. I know it's late. You're probably all required to be here, but just, bear with me. I'll be talking a little bit about myself, but then I'll dive into maternal health equity, maternal health crisis, what we're trying to do about it. So I'll talk a little bit about myself. I want to say a big thank you for having me here. This is exciting. I've been in many chapels, but I've never talked. I talked in chapels, but not on at a mic. So it's a first for me. With that, okay. So as Mark was introducing me, I'm an associate professor at Michigan State University in the College of Human Medicine. I'm in the OBGYN department. I am not a clinician. I always start with this. So I was trained as an economist. And I ended up, quote unquote, doing this type of work following my wife, which was a good decision. So as a spousal hire at Michigan State, they wanted her and they sort of tolerated me for a while. And then I had the privilege of sort of deciding what I want to do. So slowly but surely, I really got interested into maternal health, infant health, health equity topics. And now I lead a program of research really focused on maternal health, morbidity, mortality prevention, and equity, mainly equity. I forget. So population health, we call ourselves the Maternal Health Equity Lab, but we're not a lab in the sense that, we have, we do lab work. What we do is we call it population health in the sense that we're trying to influence the health of groups of people. So for example, I'll be talking about this a little bit later. We're intervening with community partners, with health systems, with providers in various counties in Michigan, and we have access to the data of the entire Medicaid insured population. Raise of hands, Medicaid. Do y'all know what Medicaid is? Okay. So it's the public health insurance in the United States, insuring close to half of the pregnancies and births throughout the US. So we have access to that data throughout Michigan. So we're looking at the county populations in various counties, whether or not, we made a difference in terms of what their interventions accomplished or not. So program of research is really focused on maternal and infant health. I say underserved, underrepresented. So think Medicaid population, which is lower income to lower socioeconomic status in the United States. I also run a little, a small but continuous program of research on tobacco cessation in Romania. That's where I come from, so I can talk a bit about that as well. It used to be a low middle income country, so that's what I mean by underserved, underrepresented. And health disparities, and I'll be talking about that in a couple of minutes. It's, racial, ethnic, rural, urban, and other types of disparities, differences in terms of health care and outcomes. And the last point I want to make on this slide is, where I started by looking at data and trying to, applying my skills as an economist. So quantitative, right? Statistics, data, trying to understand how various things influence care and health. And then now, for the last few years, I'm really trying to take the next step of, now that we think we understand what might influence care and health, we're trying to do some of those things, right? So hence the interventions. And I think I need help with the slides. Probably not that far. Maybe one more? Okay. So these are the two broad topics that I really work on. The one in red is really what I'm going to be talking about, maternal morbidity, mortality. So by morbidity, I mean, think chronic health, think there's a concept called severe maternal morbidity, which are complications of pregnancy that are some are near misses. They don't end up in maternal deaths, but some are close. Mortality is really maternal death during and around pregnancy and the first year postpartum. And really, we focus on racial disparities, mostly racial, ethnic disparities. And as I mentioned, I still run a small program of tobacco cessation and prevention during pregnancy, but not in Michigan. I still need help with the slide, sorry. So I mentioned that what I call, we call the target population. So we really try to influence, improve care and health in low-income, underserved, pregnant and postpartum populations of women. Mostly real. We work with, we try to influence the Medicaid the health of the Medicaid pregnant postpartum population in Michigan because we have access to the data, because our partners really focus on or provide care to many Medicaid insured pregnant and postpartum women. I want to take a minute to really mention the fact that we're really deeply engaged in communities, and I was hoping the bolded SBs, the Strong Beginnings program, which is I'm oversimplifying, and I know Peggy, if you're on the call, I apologize. It's a home visiting program. It's a community health worker home visiting program, and I'll talk a bit more in a few minutes. I was hoping that Peggy Vandermeulen, who's I'm acknowledging, and Celeste Sanchez-Lloyd, they're on the call. There's no call on the live stream. I was hoping they could talk a bit about their perspective as community partners. Unfortunately, they can't, so I'm going to try to represent that. But these are just some examples of who we partner with in our research, in our interventions. Community care providers, large health systems like Corewell Health, like Henry Ford Health, community programs, various mental health safety work groups in various communities, including in Kent County, Grand Rapids, in Flint, in the Detroit area. And with that, I will jump into, you might have heard about this, read about this, see it on social media, the maternal health crisis, which is a focus of, the state, the federal government, even the president's office. Again, you might have heard this, seen this, the fact that the maternal mortality rate in the U.S. is one of the highest among rich countries, among high-income countries. Focus on the second one from the left, the second number. It's the ratio per 100,000 live births is about 22. This is as of, I think, 2021. All the other countries, with Norway at the other end with 0, but all the other countries are anywhere between 1, 2, maybe 8, 10, and US is at over 20. The very last column on the right, my right, your right too, is the US Black, US maternal mortality rate, which is twice as high compared to white. And I'll get a little bit into why that is, and what can be done and what we are trying to do. The graph on the left is showing you the fact that it's an increasing problem. It has been. It seemed to be leveled off in the recent years. The graph on the right is getting more into the large disparities in maternal mortality rate across race and ethnicity. So it's mostly Black versus white. The bars are, I believe, are different years. And then the bar with, the highest, the largest numbers are the non-Hispanic Black, and then the non-Hispanic white are sort of second to the right. Much lower rates compared to non-Hispanic Black in any given year. In terms of the sheer number, so it's hundreds a year of maternal deaths. That's a lot for developed country like the US, and especially given the amount of funds that go into healthcare in our country. Hundreds of thousands experience, so not death, but what I referred earlier as severe maternal morbidity. So complications during pregnancy, at birth, postpartum. Some are near miss, so are almost end up in maternal deaths. And then millions more experience other pregnancy, postpartum conditions, less severe, but still some debilitating. And as I said, again, large disparities by race, ethnicity, and between rural and urban populations. This is really summarizing or even giving you a bit more information, but focus on the right-hand side column. large, really very large disparities in mortality and severe morbidity, Black, white, but also Hispanic white in terms of severe morbidity. And those are really the focus of most of the research we do as a group and with our partners throughout the state, and what I'll be talking about today. Okay. So one question is, or, I get asked, and I was curious too, some years ago, well, what explains this? Why is the US, seeing these large, year after year, large rates of maternal deaths? And why are these large disparities happening? So what's different compared to other countries, right? These are some potential explanations, some things that are different. Access to care. I mean, there's no universal insurance here. There's no universal access to, at least in theory, universal insurance coverage, unlike most, if not all, of the other developed countries that I was showing, high-income countries that I was showing earlier. Another example that I've seen is that there are counties, many counties in the US with no OBGYNs, so no OBGYN providers. There's no mandated paid maternal leave. I think we're the only country, if I'm not mistaken, we're the only country among those that I showed earlier that does not offer federally mandated paid maternal leave. And keep in mind that many, if not most, of these maternal deaths happen postpartum in that period of, where many of the mothers who are facing these disparities will have to return to work or otherwise don't get paid. The racial disparities are not the Black-white are not unique entirely to the US. So this is something I've learned recently, that, Black individuals in the UK are also about 4 times as likely to experience maternal death compared to white. So why is that? Some of the above, some of the factors, some of the reasons that I've discussed above and earlier do disproportionately affect Black and other minorities, and also those living in rural areas, and in general, those with low socioeconomic status. And in addition, and this is, I don't know if unique to US, but somewhat, is the multi-generational structural racism and perhaps some implicit, explicit bias that's not unique to the US. And there might be some other factors as well. So these are some of the things that we're trying to do as a group. And what I say as a group is our research lab, but also with lots of community partners, health partners, state health department, county health departments. So there are multiple contributors, right, to this mental health crisis. When I say at multiple levels, I mean, some are at the individual level, some are at the community level, some maybe, at the patient providers level, and some are just health system policy determinants. So we're trying to intervene at multiple levels, and I'll explain in a few minutes. I'll go into details. That's one. The other is, as I mentioned earlier, everything we do is community partners. So all of the interventions that we implement and we're planning they started with talking to our community partners and health partners. And really, we started with, well, if sky is the limit in terms of funding, what would you do to try to improve some of these, morbidity, mortality, and disparities. A key ingredient of pretty much everything we do in all our projects are community-based care, specifically community health worker home visiting. And home visiting, it really is what do you think it is? So it's in this case community health workers, but it could be nurses, could be social workers doing home visits to pregnant and postpartum women. Some other things we're looking at and trying to do to improve care and health is, some provider training, and at the system level, some equity-focused maternal safety bundles. And if there are any OBGYNs in the rooms, maybe you're familiar or heard of AIM, maternal AIM safety bundles. Yes, no? All right, I'm not going to go into any of that. Yes, then. Okay. So I mentioned home visiting and community health workers. So community health workers really are certified public health workers, but they're often race, ethnicity, language concordant to their clients. Oftentimes they lived or they still live in those neighborhoods. They perhaps they went through similar life experiences. So they build these trust-based relationships with their clients. In the maternal and child health context, what they do is they provide this continuous care through home visits, but also through, other ways, but mostly home visits, at least in terms of what we do and the work, the partnerships we have, through pregnancy, around birth, and then the first year postpartum. As I mentioned, they shared experiences and cultural knowledge. They have this cultural relevance, if you will, right, with their clients. They might have, as I said, lived through the same experiences. I want to get to what do we know? How do we know this is actually something that works? That's something, this community health worker home visiting, something that actually improves care, improves health. So we partner with a program, and Peggy, if you're on the call, again, Peggy Vandermeulen and Celeste Sanchez, they're our closest partners, community partners here in Kent County, in Grand Rapids. Peggy is the director of what's called the Strong Beginnings program. You can look it up. But briefly, what they do, among other things, they work with probably 24 trained community health workers and provide home visits, intensive home visiting to really some of the highest risk pregnant and postpartum women and their families through pregnancy, around birth, and I think up to 18 months postpartum, perhaps longer. So we partnered with Strong Beginnings for many years. And some years ago, we started to wonder, well, how do we test the program? How do we know the program actually works? So without going into a lot of detail, I mentioned the access we have to the statewide Medicaid data. So we've matched participants in the program to statistically matched with non-participants, right? So equivalent non-participants. We try to statistically create the counterfactual, right? So we match clients with birthing individuals who did not participate in the program, but they looked similar in terms of, the risk factors, their behavioral factors, their drivers of health factors. And again, without going into a lot of details on how we did the study, what we found, which is the next slide, that's what I want to get at, is that participation in this program, and home visiting by community health workers, and one thing I should mention, I don't know if I did, it's a home visiting that's building onto the state Medicaid nurse home visiting program. So it's a team care between teams of community health workers, coordinating community health workers with nurses or social workers and providing home visits. So participation in this program reduced the risk of very preterm birth, which is by about 40% among all the participants, and higher, so a 60% relative reduction among the non-Hispanic Black participants. That was important to find. And then when we looked at preterm, which is birth before completed 37 weeks of pregnancy, the risk reduction was about 15%. And again, higher among the non-Hispanic Black participants. So to us, the way we interpreted this is that not only it reduced these risks of adverse birth outcomes, but also disparities. I should mention that there are large disparities, black-white disparities in terms of preterm birth, low birth weight, just adverse birth outcomes in general. So this program reduced those disparities to some extent. And also on the right-hand side, program participation in this program essentially doubled the rate of postpartum care attendance at 3-week postpartum. That's important. And also doubled it among Black participants. So with that information, then, this is additional. I'm probably going to skip this slide just in the interest of time. So what did we do with this information? So here's a program that actually works. It reduces, it improves birth outcomes. It seems to be reducing disparities as well. So when NIH is it's National Institutes of Health, biggest funder of health research in the US, of any kind of health research you can think of, to the order of billions of dollars. Some 5 years ago, actually, because next week I'm actually attending this 5-year anniversary meeting in Baltimore at NIH. NIH launched this, what they called Improve Initiative. So the focus was and still is on addressing this maternal health crisis, really. So morbidity, mortality, disparities. And what they want is really, so they want some observational research, which what I mean by that is, we look at data and try to understand what influences what they really are looking for is really intervention. So they want programs that are moving the needle in terms of maternal morbidity, mortality, and also reducing disparities. So we applied for some of this funding, and I want to say because we are doing this work for years, and because we had this statewide network of community partners, including, as I said, Corewell Health, Strong Beginnings here, including partners in Flint, including now in the last 3 years, a strategic partnership between MSU and Henry Ford Health in Detroit. And all the work we were doing, I think that's probably why we were successful and got funded for the next 7 years to try to address some of these things and intervene throughout the state of Michigan. So I bring up these, what NIH calls maternal health research centers of excellence. So at MSU, so I'm co-leading one of these centers. There are 14 throughout the country funded at the same time. So it was a coordinated effort throughout the country to invest over the next 7 years about $200 million into what we call multi-level interventions. So interventions that, remember the levels that I was mentioning in probably my second or third slide, community level, intervene at the provider level, intervene at the health system level if possible, policy level. So multi-level interventions throughout through these 14 centers of research, all of them focus on the same topic: reducing maternal morbidity, reducing maternal mortality, maternal deaths, and reducing disparities. And these are sort of the general objectives that NIH set out when they were looking for applications. So what we did is, we had several meetings with many of our partners, and we put the proposal together with them. So we genuinely asked them, and the researchers as well, what do you think we should do? And we started from, if money's no issue, and then we brought it down to, okay, here's the budget and here's what's feasible. So I'll be talking next 15, 20 minutes, and then I hope I can stop for questions about the center that I'm co-leading. We called it the Miracle Center. It's not quite an acronym, but and the goal of the center for the next, we have 6-7 more years perhaps, is really to reduce, as I said, so PRAM, is our smart way of saying pregnancy-related and associated morbidity and mortality. So related is, think of it as something that's happening because of the pregnancy. Associated is happening during pregnancy, but it could be, car accident. It could be an overdose, right? So it's not necessarily caused by the pregnancy, but it's associated with the pregnancy. So we're looking at all of those types of events. And through 3 large projects, through a training program and through a community partnership consortium that's really across everything we do in the center, we're, again, we'll intervene in all these counties that you see on the map. And then in 4 or 5 years from now, we're going to look at the statewide data, and hopefully we're going to see better outcomes, better measures in terms of care, health in all of these counties compared to non-intervention counties. So I'll be talking about one of those projects, one that I co-lead. Actually, before I go into this, I should say that the entire Miracle Center, right? So when I say co-lead, I mean I lead it with one other colleague, Jennifer Johnson. She's the chair of the Public Health Department in Flint, and with Peggy Vandermeulen, who's, as I said, directing the Strong Beginnings program here in Grand Rapids. And intentionally, for the center and for each of the projects and the training program and the community consortium, we set up the whole leadership structure, if you will, so what we call the principal investigators, so that at least one of the principal investigators is a non-academic person, right? So it's somebody from the community, it's somebody from a health system. So at each level, we have, as I said, at least one community or health partner co-leading with us when it comes to decisions and what we're doing and the direction of the center and the projects. So I'll be talking maybe about 10 minutes or less about one of the projects. So what do we specifically do or try to do? This one, again, this is the one project that I co-lead, so I'm most comfortable talking about. Remember when I showed you those findings of, the home visiting, Strong Beginnings, participation in that home visiting program really improves care, health, and well, we're building on that program, and we're gonna scale it up with our partners. When I say we, I mean we, the royal we. There's lots of us. It's not we, the academics, who are doing these things. It's really the health systems, the providers, the health departments who are helping us implement these interventions. So what is the intervention? Let me first say where we will intervene in this one project. 3 counties, Kent County and Genesee, so the Flint and Grand Rapids areas, we're going to start early next year. And then in about 2.5 years, then in Detroit. So the reason we're not starting at the same time is we want, and you can look this up, a step wedge approach in which each county is going to be its own intervention and then control. So we can compare pre and post intervention within each county at the end of this project. That's hence, the step wedge, right? Step 1 is going to be Genesee and Kent starting at the same time, and then we're going to stop there. And then step 2 is going to be Wayne County, Detroit. So the partners are, I mentioned, and I will say again and again, Strong Beginnings and Corewell Health here in Kent County. In Genesee, in the Flint area, the main partners are the health department and Ascension and Hurley, large hospitals. And then in the Wayne County, it's Henry Ford Health. So multiple hospitals in the Detroit area. So what will the project be? What will we actually do? So we're going to scale up this home visiting program, right? So this partner team, community health worker with nurses, social workers. We're working with the program with Strong Beginnings to refocus some of the content towards risk factors towards maternal health and towards risk factors that we know to be relevant to the health of the mother, especially after birth. Historically, many of these home visiting programs used to focus for various reasons on the infant health after birth. So we were thinking, well, what about focusing some of this on the maternal health, and especially risk factors that are relevant to severe morbidity, risk factors for maternal death, risk factors for these large racial and ethnic disparities. And I will go into a little bit of a detail, maybe skip some of this. I mentioned some of the what specifically will this be? Will this intervention, this project? So key ingredient is this community health worker home visits, supporting and empowering their clients being Medicaid insured pregnant and postpartum women. We're going to work with providers, and I don't have a better word than just provider training in terms of trying to address some of the biases, perhaps implicit biases, work on the communication between providers, clinicians, and these, pregnant and postpartum women, and just intentionally focus all of these components on these pregnancy-related and associated morbidity, mortality risk factors. I'm going to skip the specific aims. You can read them, but essentially what we're doing, we're going to implement and then test intervention. We want to see if it actually worked. I see what is it that I haven't said here. Probably the only thing that I haven't said is that, or maybe I did, but I'll reinforce the fact that once the intervention starts, right, with partners, with health systems, with providers, with health departments, the project is not really, it's not enrolling patients. So I don't know if you're familiar with randomized trials, the idea being, you go and enroll, let's say 200 patients, and you randomize half into receiving whatever the intervention is, maybe they get some device, maybe they get some medicine, and randomize half in not getting it, right? Usual care. We're not doing that. We're intervening countywide, or as much as possible countywide, and then having access to the entire statewide data for all the Medicaid pregnancies, births, and postpartum in terms of birth record, death records, claims, and other data sources. Then we'll be able to look within counties and across counties to see if, the outcomes we're looking at, morbidity, mortality, and disparities, actually improved in the counties where we intervene compared to the counties where we don't. I might just skip some of this dry stuff. So I mentioned the fact that, actually, no, this is actually, so I'm not going to skip this. So I mentioned the multi-level interventions, right? This was, if you recall, this was the call and the funding, what NIH wanted to fund. And the thinking being, there's no one thing that, if done, that's the silver bullet that will solve this, that will really move the needle. Thinking is there are multiple factors, multiple determinants of this maternal health crisis. So there needs to be interventions need to be at multiple levels. So in our case, specific case is we're intervening at the community level, which is this community health worker home visiting model. It's entirely community driven. We're intervening at the practice of provider level. So think provider training, again, for lack of a better term here. The idea being to work with providers to improving patient-provider interactions. So I'll give you one quick example. There's research showing that Black women, they don't feel they're heard this in the same way when they say things like, I'm in pain, or, I have, whatever the issue might be. They're not heard in the same way as white women are. So that's just one brief example of in terms of content that we might work with, trying to address these interactions, right? So, and we're going to work with patients, how to communicate better, perhaps, to be aware of some of the risk factors that some of the clients, some of the patients they will see they have. And through the community health workers' home visits, we're going to work with the clients as well to empower them to, increase the knowledge and just become just better advocates for their health and participate in the health. And at the system level, without going into details, I will just say this: the system level piece of the intervention is what we call maternal safety bundle. So, but at the community care setting. So any non-hospital setting care setting, it's fair game in terms of partnering with them to adopt these. When I say maternal safety bundle, think of checklists, right? So standards of care. I'll give you one quick example. There's a community care safety bundle focused on the transition between prenatal to postnatal transition, right? Which is key. The key is to quickly get a postnatal checkup, address any risk factors that might be there, check on the mom as well, not just on the infant. So it's just one example. I'm probably going to spend a minute on this. So these are more detailed. I'm trying to get more in depth in terms of, what exactly is it that the community health workers will address? What will they talk about? What will they discuss? How will they specifically empower their clients? So these are some examples. The key, I think, of this slide is that all of these, or the vast majority of these interactions, home visits, will be delivered by what we call culturally concordant community health workers. So race concordant, ethnicity concordant, language. So they speak Spanish when they see Hispanic clients. The other thing I would mention, I don't know if key, but it's relevant. So home visiting is fairly common. So most states, Medicaid does offer home visiting. So our thinking was, if this works, if it actually turns out that it works as an intervention, it's easily scalable. So it could be easily then scaled up in other states as well, because there is, the home visiting infrastructure is there. Probably less so in terms of community health workers, but it's building. So our thinking was, it would be relatively easy to scale up. I want to skip this one. And this one as well. Actually, let me spend 30 seconds. So for those, for clients, patients with pregnancy complications, or maybe they have a chronic disease, maybe they had a prior preterm or a low birth weight previously. These are additional topics that community health workers will touch upon with those clients. So at the practice level, at the provider level, again, I'm using the word training. It may not be the best word, but it's really what we're trying to do is improve the interactions that providers will have with their patients. The focus being on communicating better, listening, perhaps some implicit bias, cultural relevance, really. And the focus is on really dialogue, right? Communication between the provider and the patient. And very briefly, this is the third level. So remember, community level, which was the community health worker home visiting, provider level, that training, communication, better communication. Then at the system level, this is the system level portion of the intervention. These are these maternal safety bundles, these checklists, standards of care on various topics two things here. One, all of these bundles, safety bundles, are for community non-hospital settings. And the reason is for many years, there's a similar effort has been going on in hospital settings. So this is addressing all other providers, non-hospital providers. And the second key thing here is that all these bundles, safety bundles, checklists, if you will, standards of care were developed with equity in mind. So intentionally with equity in mind. So what next, I guess, is the question. So let's say the intervention works. So let's say in 4 years from now, we look at the data and we see amazing findings. We see that these counties where, we intervened are half the rates of morbidity and mortality. I'm exaggerating, but, one could hope. Perhaps the most self-sustainable, well, the funding will end in 6-7 years, the funding for our research center. Perhaps the most sustainable, in my opinion, are these maternal safety bundles. So think of, if community care providers adopted these standards of care and then we see, oh, the intervention works, I'm thinking they will just keep doing those things. I guess we'll have to, remains to be seen. The provider practice level perhaps is likely to be sustainable. Again, if it's part of an intervention that works. The least sustainable, at least for now, with the information we have now, is the community health worker home visiting and integration of community health workers in the continuum of care. And I'll explain why. Before I go into why, I think it's the least sustainable. This is really a summary of what I've showed, or what I hope I don't know if I convinced you, but I show you some evidence that it's a strategy that seems to be improving care and health. It's a strategy, this community health worker home visiting, that seems to be reducing disparities. So why did I say it's the least sustainable? Mainly because community health workers, there's really no, for now, sustainable financial model for community health to set up community health programs. So I'll give you the example of Strong Beginnings. It's mostly funded through grants. Medicaid started to reimburse community health workers as of last year, but the reimbursement rates are so low that from what we've seen data from Strong Beginnings, it probably covers about half of the actual cost of the program. So that's probably the main reason for now that I say, well, it's hard to sustain such a model to include community health workers in home visiting. The other thing, focus on the bullet at the bottom that, yes, there's evidence, we provided some, but there's other evidence that actually community health worker in home visiting settings actually do improve care and health. With the current funding and the current reimbursement, it's really hard to offer decent living wages for community health workers. And there's a fairly large turnover. They're just not staying in the profession, unfortunately. So what to do, I guess, and what to do. And I think this be my last slide, yeah. For me and others like me, academics, I think we can continue doing the research, bringing the evidence, showing that it's not only programs like this work, but they have a positive return on investment. Show of hands. Who knows what that is, return on investment? Okay. So in this context, the way we looked at this is we know what it costs, right? We have our partner Strong Beginnings, and they gave us data of, well, this is what it costs to pay, reasonable wages to our 24 community health workers. This is what it costs to, salaries for community health workers, supervisors, administration, all the other costs. And then we have evidence that it reduced preterm birth. So there's data on what the excess cost of a preterm birth is for health systems. So we compared the cost of the program to reduce these preterm rates and what it saves by reducing. And when we compare those two numbers, those two dollar amounts, there's a positive return on investment. What that means, the cost of actually running Strong Beginnings compared to the savings are higher. So we can continue to provide that evidence, which we are. We can and we will continue to advocate with partners, state health departments, policymakers, politicians, because in the end, that's really the way to change things. And perhaps advocate for a sustainable funding plan for this, race, ethnicity, concordant community health worker workforce. And I want to stop. Thank you all, and see if I still have your attention. Thank you. So we have about 10 minutes if you want to stay.
Yeah. Is this on? We can take some questions from the room. I'm also checking online. Any questions? I can start. So Kent County, Genesee County, Wayne, in general, I'm thinking that's more urban. Is there a reason why those three counties were chosen? And is there any thought of expanding it to more rural counties, maybe Northern Michigan, UP?
Trying to quickly get back to that map on. So for this particular project, that's where our partnerships were, the largest partnerships to implement this intervention. So we were partnering with Strong Beginnings for many, many years. So it was just, that was the natural continuation of our partnership. Then we started probably 4 years ago. There we go. We started working with partners in the Flint area as well. And then for 3 years now, we're in this partnership with Henry Ford Health. By we, I mean MSU. So those were the natural partners for us to implement this type of intervention. And yes, it's a lot of population. So it's not by mistake. I mean, it was intentional that, the whole Detroit area, which is, 2 million, 2.5. The Grand Rapids metro area, which is another million or so. And then Flint, again, this is where we had partnerships, but this is just one of the 3 projects. The other 2 are intervening in all the other counties that you see, in various colors on the map, including some of the rural ones. So I didn't talk about the project that's intervening in I think the yellow colored, right. So that's not telehealth. That's I'm trying to use a different word here. So so the intervention is technology based, right? So it's the idea being that intervening in some of these rural counties, but using technology, which by technology, I mean a web-based app to screen and then feed back the information to the providers and back to the patients as well. It will increase access. So I'm giving you a long answer why one project was just 3 counties, because that's where we had partners and that's where most of the population is. But some of the other projects are intervening in rural areas as well.
Other questions?
Thank you for sharing this really invaluable and important work. I had a couple of questions about what pre-post measures you were actually looking at. So what sort of things are you looking at, before the intervention and then post-intervention? And what sort of health, mental, physical, social health are you looking at? And then you being an economist, do you have access to that sort of data as well?
So the main outcomes, right? So the way NIH thinks and any other funder is, okay, tell us what your primary outcome is, tell us how big your sample size is, and tell us if you can actually measure any difference. So there's something called power analysis. So we chose this really broad score, which is the pregnancy-related and associated morbidity and mortality. So that's a score that includes a large number, it's probably 120, if not more, various conditions. Some are severe morbidity, some are less so. So that's the main outcome. But then the one that's more commonly used, it's what's called severe morbidity, severe maternal morbidity. So that's I want to say 21 conditions that are, well, severe enough that they can complicate a pregnancy to the point of a near death experience. And then also mortality, pregnancy-associated mortality, which is death within the first year postpartum. So those are the main ones. We're able to look at all of these pre and post because the statewide data that we're using, the Medicaid statewide data, that's being collected by the state every year. So birth records, death records, Medicaid claims. There's a statewide home visiting program, the nurse home visiting program that I mentioned. It's called Maternal Infant Health Program, MIHP. All of these data, individual data for the entire Medicaid population, pregnant and postpartum, is being collected, and we have access to it since, well, not since, but we have since longer than 2016. But the data we work with now goes back consistently to 2016 dates of birth, and we'll have it, going forward through 2029, I want to say, and then we end the project in 2030. So all of these we observe over time at the individual level, so we can aggregate at the county level, we can aggregate. Perhaps at the provider level, that's a bit difficult to assign, but at least at the county level is that's our unit of aggregation. I also wanted to. I keep pointing to my phone. We're also going to look at. So we're going to look at, first of all, is intervention working? Just overall, yes or no? We look at the outcomes, but then the question is, well, how did it work? Assuming it will. So we'll look at some mechanisms of effect, right? So we're going to look at access to care. And for that, we're looking at whether or not they get appropriate prenatal care. There are standard measures. We're looking at quality of care. And I think for that, we're using whether or not they receive their prenatal care in the first trimester, if I'm not mistaken. And we'll look at, well, I call them social conditions, but they're now referred to as drivers of health. So we're looking at access to enough food, appropriate housing, and transportation. These are the main things we're looking at. The data is extremely rich, and we'll be looking at other things, but these are the things that we said we will investigate. Oh, the main one is race and ethnicity. That's the main. The main objective of this project is one of the main objectives is to reduce disparities. So yes, race, ethnicity. The other project that I mentioned is going to look at rural versus urban. Others that we usually look at is age. We have hundreds of thousands of data points, so we can look at lots of things, but age. In the past, we've looked at income levels, so we don't know exactly what incomes the families have, but we have other measures that give us an idea. For instance, are they like cash transfers, right? If they get cash transfers, then we know they're lower income, even within the Medicaid distribution. I could go on and on, but I don't know if there are other questions.
So I'll just mention to Celeste, who you might know from Strong Beginnings.
Oh, yeah.
She put in the chat that Strong Beginnings is a healthy start program. We are one of 101 projects across the country and one of 5 in the state of Michigan. So I just wanted to share that.
Thank you, Celeste. I was hoping that yes, they would be able to actually come in and speak, but then I realized it's not a Zoom. So thank you, Celeste.
We might have time for one more question if there's one in the room. Oh, she's deferring to you.
Thank you. Are these slides going to be available?
We can share.
Okay. And then
Might remove the comments, but Sure.
What are the plans for partnering for the education when you're looking at provider and practice level education? What's the plan who are you going to partner with for that?
Good question. Trying to see if I have anything. I'll tell you what we're doing now, but I'll give you some examples. So one example is we work with, I don't know if she's still with Corewell Health. Maybe Celeste put it in a chat. Work with the pastor. I mean, she's trained and she's delivering these again, I'm going to use the word trainings with providers, with residents in various settings, at in these 3 counties. But what we're doing now is, so when I say we, again, it's not we, the academics. We don't really know how to do these things. We have community partners who are trained to do this, and they've been doing it for years. So I'm not giving you much detail, but we're working with individuals who are doing this type of trainings, think implicit bias, think communication, think cultural relevance, all of these things, but they've been doing this for years. And we try to partner with all, large health systems and small providers and anybody, who would touch these Medicaid patients and clients during pregnancy and postpartum care. I'm giving you a vague one, but.
All right, let's thank Dr. Meghea. Again, I just want to thank Dina Eula one more time and Dr. LaRue. And thank you all also for coming. I know there was a lot going on campus tonight, so always appreciate the great turnout that we get here at Calvin, and have a good rest of your evening. Thanks.
Thank you, everybody.